Dr. Burris, this morning at the Community Oncology Conference, you discussed a lot of provocative new therapies, among them mAb inhibitors and nanoparticulate lipid formulations that are being used in clinical trials. Could you tell us a bit about that?
The MET inhibitors are a fascinating new class of anti-cancer agents. We've known that the MET pathway is activated in a number of the more aggressive tumors. We've learned from studies of the mAb antibodies as well as some of the oral MET inhibitors that in fact it's important to determine which patients are most likely to benefit. By taking tissue from those patients' tumors, we can study that with simple immunohistochemical staining and then ascertain if they in fact overexpress MET and are an ideal candidate for blocking that pathway. The results from the trials preliminarily show that in fact those patients that overexpress MET and receive a MET inhibitor do much better. And then, just as importantly, those patients that don't overexpress MET and receive a MET inhibitor actually don't do as well and actually shouldn't receive the therapy. A very important assessment in this time of financial constraints to get the right therapy for the right patient at the right time. The nanoparticulate formulations of various new agents is also quite interesting. It gives us the ability to give some very potent therapies in a well-tolerated fashion. We talked a little bit about one of the nanoparticulate formulations coming from Alnylam. Alnylam has a technology platform that looks at placing that in a lipid formulation, and they've been able to show in clinical trials that they can give a chemotherapeutic as well as a biologic together in that nanoparticulate formulation and actually shrink tumors. Interestingly, that technology also will be useful for delivering therapies to other diseases, and there's works ongoing in such areas as hypercholesterolemia and hyperlipidemia to get a better therapy to the patient in a more tolerable fashion.
You mentioned that therapy has to go to where the patient is, and the patient is in the community. What are some of the initiatives that the oncologists could be involved in to increase participation in clinical trials?
So getting the community oncologists involved in clinical trials is important. The only way we're going to get the answers to these key questions about which therapies are best and the sequence and the combinations of those therapies is through clinical trial work. I think we often forget that every new therapy that's made available to us today has come as a result of traditional phase 1, 2, and 3 testing. Now that patients have so many therapeutic options, they're often kept in the community, where they can receive better care, receive the support of friends and family members, and I'm a strong advocate of that. So we've got to get that community oncologist involved in clinical research, giving these investigational therapies. Things we can do to provide the support system. Many of the back office functions, the regulatory burdens, the education, the training, the data management, many of those functions can now be done electronically. So I think banding together in broader networks and consortiums, providing that infrastructure support with good oversight, with quality assurance and other factors should really be able to assist the community oncologists in being able to participate in more clinical trials.